This case study focuses on Patrick, a 78-year-old male. Patrick's history includes left-sided heart failure, chronic obstructive pulmonary disorder, and a myocardial infarction. He has a long history of smoking and is overweight. He also has tiredness, dyspnea, swollen legs, and coughs regularly. Assessments show a blood pressure of 135/85 and 155 beats per minute. Patrick suffers from regular coughing and dyspnea, both relating to his COPD and left-sided heart failure. COPD is an irreversible obstruction of the airways. Patrick's long history of smoking is a contributor to his COPD, as cigarette smoking causes hyperplasia of goblet cells, which stimulates the hyperproduction of mucus. Coughing is an attempt to unblock excess secretions and clear the airway. Furthermore, smoking causes airway remodeling by damaging bronchial walls and overinflating alveoli, which results in a smaller surface area for gas exchange with fewer larger alveoli. This impairs our body's ability to adequately absorb oxygen. This results in Patrick's dyspnea, as Patrick must compensate by increasing his work of breathing. Patrick's age also contributes to COPD. Aging causes the lungs to lose their elastic recoil as the peripheral airway loses their supporting tissue, which aids in the structure and function of the respiratory system. There is fewer functional alveoli and gas exchange becomes impaired, promoting dyspnea. Left-sided heart failure is where the left ventricle of the heart is unable to adequately pump blood out of the aorta. This leads to the backflow of blood into the atrium and pulmonary veins. Blood then diffuses into the alveoli, causing pulmonary edema. This can inhibit gas exchange and cause dyspnea and fatigue. Furthermore, Patrick's overweight size can impact his breathing, as increased fat on his chest and abdomen impedes respiratory mechanisms. This impairs gas exchange and increases his work of breathing. A normal adult heart rate is 60 to 100 beats per minute. However, Patrick's is 155 beats per minute. This is known as tachycardia. This can be caused by the release of catecholamines by the sympathetic nervous system as a response to stress or as a compensatory mechanism for decreased blood pressure, cardiac output, hypoxia, and hypoxemia. This ensures that the tissues receive an adequate blood and oxygen supply for cell respiration. Patrick's heart failure is associated with his tachycardia as it decreases the stroke volume. Patrick's risk factors that contribute to his heart failure include his age, history of smoking, myocardial infarction, and weight. With factors mentioned before, Patrick's COPD, potential atherosclerosis, and anemia are factors that could contribute to hypoxemia and hypoxia. Patrick's COPD can cause hypoxemia as oxygen intake is decreased due to limited airflow and obstruction involved in COPD. As mentioned before, Patrick's risk factors such as aging and history of smoking have contributed to his COPD. Atherosclerosis is a hardening of blood vessel caused by plaque. It can contribute to hypoxia as the lumen of the blood vessel decreases and restricts the flow of oxygenated blood to tissues. Patrick's increasing age, past history of smoking, overweight status, and dyslipidemia, as displayed by his abnormal lipoprotein levels, increases chances of atherosclerosis. Patrick's low hemoglobin levels indicate anemia. Decreased hemoglobin causes hypoxia as there is reduced oxygen carrying capacity within the blood. In anemia, in order to compensate for hemoglobin loss, interstitial fluid is shifted into the blood, which thins and increases blood volume. This state of blood flows faster and causes an increased heart rate to facilitate blood flow. Likely causes of Patrick's COPD is his smoking history and increasing age. As discussed in question 1, smoking causes hyperproduction of mucus and permanent airway remodeling. Along with smoking, Patrick's increasing age means that his respiratory system is much less effective at function and repair. These changes to Patrick's respiratory system consequently result in COPD. Potential atherosclerosis, anemia, and COPD can contribute to Patrick's developing left-sided heart failure. As mentioned in question 2, these factors can cause hypoxemia and hypoxia. The heart must compensate for this by increasing the cardiac output to hypoxic areas and maintain tissue perfusion. This increased cardiac output can cause immense stress to the heart. This can lead to the hypertrophy of the left ventricle, meaning that the myocardial mass increases. Eventually, hypertrophy decreases the contractility of the left ventricle and its ability to adequately pump blood out of the aorta. Anemia also stimulates an increase in the blood volume. This increased blood volume can also promote hypertrophy. Patrick's COPD causes heart failure due to systematic inflammation. COPD causes the inflammation of blood vessel lining, by increasing the inflammatory markers such as cytokines and chemokines. Inflammation damages and narrows the blood vessels and subsequently increases the blood pressure. The rise in blood pressure increases the cardiac workload, leading to ventricular hypertrophy and dilation, and eventually left-sided heart failure. Patrick had a myocardial infarction to his left coronary artery, possibly due to atherosclerosis. The left coronary artery supplies blood to the left side of the heart. Therefore, a myocardial infarction to this artery could cause ischemia and necrosis to the left ventricle. This dead myocardial tissue can cause the heart to have contractile dysfunction, thereby causing left-sided heart failure. Patrick's left-sided heart failure could be caused independently by his myocardial infarction or possibly by his COPD, whereas Patrick's COPD likely originated independently from his smoking history and increasing age. Patrick is at risk of developing right-sided heart failure due to his COPD and left-sided heart failure. Hypoxia caused by COPD reflexively simulates small pulmonary arteries to vasoconstrict in order to divert the blood to well-ventilated areas and maintain the oxygenation of the blood. Eventually, the vascular smooth muscle of the pulmonary arteries thicken and decreases the lumen diameter of these vessels. This subsequently increases the resistance and pressure within the arteries, thereby causing pulmonary hypertension. Since pulmonary arteries are connected to the right ventricle, the resistance to the ventricular ejection of blood or afterload increases. In response, the right ventricle undergoes ventricular remodeling in the form of hypertrophy to increase the contractile power and maintain the cardiac output and tissue perfusion. Dilation and enlargement of the heart chambers can also occur if the pressure remains elevated. Over time, long-term hypertrophy and dilation can decrease the ability of the right ventricle to contract and maintain cardiac output. Patrick's left-sided heart failure can also cause right-sided heart failure, as the ability of his left ventricle to eject blood is impaired. This subsequently causes the backflow of blood into the left atrium and then the pulmonary circulation. This increases blood volume within the pulmonary circulation, also contributes to pulmonary hypertension, and in turn increases the right ventricular afterload. Consequently, this causes ventricular remodeling and eventually right-sided heart failure. Patrick has hypertonemia. This is caused by the RAS that was activated by his heart failure in response to decreased cardiac output. The RAS stimulates sodium retention in order to increase the blood volume. Hypertonemia affects neurological health as hyperosmolality can lead to neuronal loss. Patrick also has hyperkalemia. Decreased perfusion to the kidneys caused by chronic heart failure can lead to renal failure. As a result, potassium from the blood cannot be excreted by the kidneys. This can cause Patrick's fatigue. Patrick has hypocalcemia. His hypocalcemia could be due to Patrick's potential kidney impairment, as the kidneys activate vitamin D, which helps the intestines absorb more calcium. Due to a decrease in calcium to facilitate nerve impulses, neurological impulses are delayed within the calcium channels of axon terminals. Hemoglobin is a protein in red blood cells that assist in the transportation of oxygen and carbon dioxide to the body's tissues and organs. Patrick's hemoglobin level is low due to factors stated in the table. If the brain is deprived of oxygen, anaerobic cell respiration occurs where lactic acid is produced for energy. Too much lactic acid can cause lactic acidosis, which can lead to seizures. Fatigue and dizziness can be caused by hypoxemia through tissue hypoxia. Patrick's history seen in the table causes high levels of LDL and triglycerides and low levels of HDL. These abnormal lipoprotein levels can promote atherosclerosis formation, where sufficient HDL removes cholesterol from the blood to the liver for metabolism. When atherosclerosis occurs so close to the brain, blood flow within these arteries becomes constricted and hypoxia can occur. This can result in a mini stroke. Patrick's lifestyle condition seen in the table causes insulin resistance. Hyperglycemia can disrupt the blood-brain barrier, thus causing a cerebral edema. This increases the chance of a hemorrhagic cerebrovascular accident. Prolonged periods of hyperglycemia can result in type 2 diabetes mellitus. Type 2 diabetes can damage small vessels in the brain and interfere with nerve communication, thus resulting in vascular cognitive impairment. An additional abnormal blood result may be a high concentration of carbon dioxide within the blood. During cell metabolism, carbon dioxide is produced and then removed from the body through the lungs during exhalation. Patrick is likely to have carbon dioxide retention due to impaired alveolar gas exchange and carbon dioxide excretion, as the airflow in and out of the lungs are limited and obstructed. This is the result of airway remodeling and obstruction that occurs within the lungs due to COPD, as mentioned in question 1. The increase in carbon dioxide within the blood would be reflected through the measurement of particle partial pressure of carbon dioxide within their arterial blood. Patrick would have a high partial pressure of carbon dioxide that would exceed 45 millimeters of mercury, as a normal range of partial pressure of carbon dioxide is 35 to 45 millimeters of mercury.